Okay, that's super. So thank you for the introduction. Oh, I need a clicker. Oh, it's here. That's wonderful. So, because this is the Jubilee Conference, I thought I would just give you a little bit of a personal history around what happened 14 years ago now. So, in 2012, I attended it was then a 5-day workshop that Harold came and delivered before the main conference in Bern. Anybody who was there last night will understand. Apologies if you weren't. And I was a postdoc fellow at that time, and I had done a PhD in behavioural medicine, lots of really rigorous research methodology, and I was applying that to behaviour change, and that was great, that was fine. But I was so inspired by actually adapting that and applying that rigorous methodology to spiritual care. And the reason I was so inspired by that was because certainly in my clinical practice up to that point, I felt there was a gap, there was something missing. And also kind of personally in the fulfillment of what I was doing in my role, I also felt there was a bit of a gap. So I went back to the UK and, I tried to kind of move that forward where I was, and it wasn't really happening. So I ended up changing jobs and going to a place where, the holistic integrated care and research around that and bringing that into nutrition and dietetic care was really something that the university wanted to look at. So I established a niche area of research. And, I got grants, I had lots of PhD students and research staff, did teaching, training healthcare professionals in that area. And that all sounds really successful. And also, a great highlight was we hosted the ECRSH at Coventry University in 2018. But, and this is a big but, and probably something that if you're in the field, you'll be familiar with. If you're not in the field and you're moving into it, it's perhaps something to bear in mind as you go forward. That because this is a niche area and it's not an area that everybody kind of understands or aligns to, it can be really hard to get the funding that your university requires you to have in order to keep your job, in order to kind of keep going. And so because of that, and I didn't sort of lose interest, but I had to progress and continue to do other things where the university found that I was extremely useful. So that's how I've kind of ended up in more leadership and management roles. And I could have switched, I guess, and changed my research back again or adapted it to something else. But naturally my career kind of changed and went forward into leadership and management. But that has also allowed me to keep this going in a small way. And I hope that what I show you today is a little bit of that journey, and you'll see that there's been small gains along the way. But I would just like to encourage you that small gains can be meaningful and can be fruitful. It's not all about the big puff, and in fact a big puff of smoke sometimes disintegrates, doesn't it? It's more about that steady, slow, consistent, persistent way of going. So that's from a personal point of view. I also like to declare a bias, so I will declare my bias is I'm a Christian, so I look at things from that perspective. But I'm also declare a scientific, I don't know if I would say a bias, but I am grounded in evidence-based care. I do believe 100% we should be supporting patients only in stuff where there's good evidence of effectiveness and there's good evidence of support and that things will be helpful. And the other thing I'm entirely grounded in is person-centered care. We need to go where the patient takes us. We need to put the patient in the middle. Their needs are first. They're not there for us, we're there for them. And it's around, what do they need in the moment? And whether that's biological, whether it's psychosocial, whether it's spiritual, that's what we need to kind of find out and move with them in that. Okay, so I have rattled on a little bit, sorry. So why this why kind of the biopsychosocial spiritual model in nutrition related things? So I've said a little bit already, but nutritionally sound, psychologically informed interventions, they have a lot of good things about them, but I do feel they've got a gap. And that's come to me from patient stories, from what people would tell me in the clinic room. And as we know, these things are often very difficult to sustain as well. We get poor outcomes, relapse, disengagement, distress. All these things can persist. And so in order to improve that kind of intervention, improve the outcomes from nutrition and dietetic aspects of care, what role does meaning, identity, and spirituality play? And I guess that's been the big question around my work. So I'm just going to briefly give you a whistle-stop tour of some of the publications that I've done to address this. And first of all, going through identifying an unmet need, exploring what the current practice is, intervention development, looking more broadly at other interventions, and then thinking about where are we now in terms of actually implementation into clinical practice. Because we can do all this research, but it's no good if it sits on the shelf and doesn't actually make a difference. So, in terms of identifying unmet need, so this was a systematic review, just looking at the patients that would go to see dietitians, so dietetics. We don't tend to use the term patient in the UK, we use the term service user. I don't know if any other countries use that, but we say service users, they're users of our service. So do dietetic service users experience unmet spiritual or existential needs, and are those addressed? So that was the key thing around this systematic review. So it was, we looked at 1,433 records, and they had been identified through MESH and keyword searching for spiritual care and nutrition and dietetic practice in those databases. In the end, we included 13 studies, and these were mixed design, some quantitative, some qualitative, but we ended up doing a narrative synthesis due to the heterogeneity within those. In terms of the evidence, the quality of evidence from this was medium quality. It wasn't high quality. And I think that's, obviously when you do a systematic review, it's very important to look at the risk of bias in the studies, because, just one study that claims something without that critique of the methodology, we need to actually be critical about that methodology. Is it really proving cause and effect, or are there confounding variables, etc.? So, overall, I'm just summarising here, but overall I'd say it was medium quality evidence. And I would say I think it's got better over time and better over these 10 conferences, but sort of at the beginning, a lot of the evidence in religion, spirituality and health was actually quite low quality. It was that correlational study, not that randomised controlled trial. So it's important to think about that. But the key findings were unmet spiritual needs were present in all those included studies, and that included patients with cancer, diabetes, heart failure, and COPD. And interestingly, it was present across religious and non-religious groups, and it was associated, where that need was associated with psychological distress. So that kind of highlighted that there was a gap, and that we looked at clinical guidelines as well, and there was quite a lot of guidelines around dietitians being involved in end-of-life nutrition decisions around to feed, not to feed, that sort of thing. But really, like I say, the quality of evidence was that there were no trials of spiritual care being delivered by dietitians, and spiritual determinants were largely unaddressed in routine care. But really the findings showed that for those who were coming to see dietitians, the need was there, but it was neglected. So kind of that gave an indication that there was something there that people wanted, but that wasn't being addressed. So just thinking about then, well, what was the current practice at the time? This was just a small study, but it was the first study to actually look at the role of UK dietitians in spiritual care and look at how do they currently practice? Are they practicing this area, and what are the barriers? And so, like I say, it's a small study, so that's the main limitation. We opened it up to everybody, but it wasn't, there wasn't a high response rate. But of those who did respond, these were the key findings. That basically they did find that service users had spiritual needs. And when they came across those needs, they listened well. So remember, we've talked about spiritual care. A lot of times we've talked about listening and how important and how therapeutic it is to listen. So, that listening well was really good. And then the other thing that they did was encourage them in their own, not the clinician's own, but the service user's own spiritual or religious practices. So looking at what they were using themselves in order to help themselves and to move forward, and in getting alongside and encouraging them to do that. And then the key thing was that, and I think we found this in other professions as well, dietitians would like training so that they can provide spiritual support more confidently and effectively. And the reason for that was in order to improve service user outcomes. This study also had some qualitative aspects to it. And the qualitative themes were around intention. There was a positive intention there to provide spiritual care, and the major barrier was came under the theme of inadequacies, and that was to do with lack of training. And then an interesting area as well was there was emotional labour, and this was particularly if a clinician held a conflicting belief with what a service user was wanting, or what they felt was right. There was a bit of emotional labour there, and this worked in several directions. This was around people being very concerned and not wanting to sort of impose their own views, and being quite careful about that, and sort of making sure that they didn't do that. But the other thing was, and I think we had an example already where, say for example, the Jehovah's Witness belief around blood. People would struggle with that and found that emotionally, laborious, that they wanted to give blood. They knew that there was that was the right thing, but the beliefs were problematic around that. So there is some emotional labour in this. So I think thinking about not only the service users but healthcare professionals and walking in this whole area of spiritual care has a impact on them as well. So in conclusion on this study, the dietitians viewed spiritual care as an important aspect of practice, and this was regardless of their own religion and spirituality. And they felt that training was needed to improve confidence and reduce uncertainty and provide better support. And although it was the first study of its kind, it was very small. So I'm just going to talk a bit now about a spiritually integrated intervention that we have developed and tried and tested around people with emotional eating problems. And this was from a Christian spirituality perspective, and there's kind of 4 publications around that so far, and I'm just showing it to you to give you a sense of how this work is developed, but also how an example of how spiritual care can be integrated within biological psychosocial aspects, because it's really important to remember that it's integration. It's not one or the other. I think it's really, we mustn't sort of replace things that we know are good. I think that's really important. So there are 4 papers: sequential design with intervention development, and how that intervention was developed is in the protocol paper, the feasibility study, an embedded qualitative study, and then the randomized controlled trial protocol. And so it was a mixed methods approach in a community setting, and the community setting was churches. So the principles behind it and the intervention components were intuitive eating versus dietary restriction, and this is a different approach to where you might think that people have to go on a restricted diet to lose weight. It actually is around bringing some liberation into eating and helping to reduce problems with that. I'll show you how that works in a moment. And then psychoeducation, so around nutrition, good nutrition practices, around behaviour change, all those sorts of things. And then the Christian spiritual principles and reflection was kind of integrated into that, but that was as a sort of an optional extra, so people could choose whether to do that or not. It was in group discussion and support, and there was versions in person with paper copies and also online on a digital platform. So this is kind of what we would call a sort of diet binge cycle, if you like. So if you have a problem with eating and emotional eating, often you will be at the point of, oh, well, I've not eaten what I think I should, so I'm going to restrict. And you try and restrict your intake, but that's really difficult to maintain. And then you go into a bit of a cycle, guilt and shame because you haven't been able to manage to keep that strict dietary restriction. So then you just give up and eat more. And then you think, oh my goodness, I now need to restrict. And forever you're going around in this kind of diet sort of binge cycle. And I'm not necessarily talking about, although it's more prevalent or more, not prevalent, more intense in kind of binge eating disorders and things like that. I'm talking about this just in normal sort of emotional eating and people struggling with obesity. So it kind of tends to be quite a regular thought pattern. And what I'm going to show you now is just the intuitive eating approach. So this, rather than encouraging people to restrict diet, it does give them permission to eat, and then, but really it's around learning to listen to satiety signals and hunger signals, and eating in response to physiological hunger, rather than ignoring that and then not being able to sustain it. So recognizing hunger and fullness is a really important part of this intuitive eating. And then, theoretically, that should then help to improve body appreciation, self-acceptance, less emotional eating. And again, so you can see that we're sort of spiraling out of that problem. And then the unique bit around integrating spiritual care was around these principles of Christian spirituality, around finding freedom, but having freedom with responsibility, looking at love, forgiveness, and acceptance by God, and exploring spiritual needs that can be met by God. So you can see that was the kind of integration of spirituality in that model. So just to give you some results, this was started off as a feasibility study, a single pre-post study, recruited through church networks, non-clinical sample, 10-week intervention, intention to treat analysis with baseline observation carried forward. In the paper, you'll be able to see the detail of the results with the confidence intervals, but this just gives you a sense of magnitude of the difference in scale that pre and post for this sort of feasibility. So the first thing when you do a feasibility trial is actually you're seeing, is it is it feasible? Would it work? Are people going to come along? Can you recruit? That sort of thing. So there was good recruitment, good response rates. You can see a big reduction in emotional eating, improvements in intuitive eating, in mental well-being, and spiritual well-being, and quality of life, and a reduction in the others. Certainly the weight wasn't particularly significant, but the higher magnitude of things. But as a feasibility, it wasn't powered to determine effect sizes, which is why we've gone on and done the randomized controlled trial. But it provided promising results. And then within the embedded qualitative study, these were semi-structured interviews carried out after participants had completed the program, and they were transcribed and analysed using deductive thematic analysis. And these were the themes that came up. At the start, God and food issues were separate. So there were people that were saying to us, well, I've always had a problem with food, but I've got a great relationship with God, and I've never kind of allowed God in to kind of how I feel about my food. So that was sort of an example of somebody's quote around that. But then as they talked about, as they went through the program, they began to use faith as a resource rather than keeping things separate. They found the eating freely part of intuitive eating quite challenging because they were used to being restricting. But then, once they got used to that, there was an empowerment and enjoyment in that, and they loved the fact that the program was addressing more than just weight issues. It was all that psychosocial spiritual element. And interestingly, because this particular one was in person in groups. They were sitting with groups with strangers, and one of the themes that came out that it's not always easy coping with other people's problems when they're discussing things. So that's quite an interesting finding and something to think about. So we then went on to move into a cluster randomized controlled trial with 2-year follow-up. Although this has been completed now, it kind of came towards the end at COVID, so everything went a little bit skew-whiff in terms of managing to get all the data and all the follow-up. But we've got the results, and we will be analysing that at some point. But just to say preliminary, just the sort of looking at the data, it does show that there is a significant improvement in the primary outcome, which is emotional eating. But you'll have to take my word for that because I haven't published it and written it up yet, but I will do. So that was one of our own interventions. So this is just this is unpublished at the moment, but I thought it was interesting to present here. So this is a question from one of my PhD students who has done a systematic review to look more generally at all the interventions and what is the difference in efficacy of religious and spiritually integrated interventions compared to control interventions to improve outcomes in adults with obesity, eating disorders, or disordered eating. So there were 8,483 unique records, and 35 included the randomized controlled trials that met the inclusion criteria. The follow-up range was quite wide, and again, reviewing for the risk of bias within these studies, there was low risk of bias in 16 of the studies, medium risk in 15, and high risk in 4. So typically a low risk study, it would be really clear to see how randomization happened, and that you can kind of there wasn't much dropout from randomization, so that you're able to kind of have that causative aspect to things. Whereas the high risk of bias, they might have been unclear in how they've described how you randomize somebody, or there might have been half of the people dropped out in one group and the results no longer maintain their randomization, which allows that spread of characteristics across 2 groups or however many you're randomizing. So this is just to give you an indication around the spiritual and religious components that were in these. A lot had the mindfulness-based practices, that was 17 studies. Meditation as well, some were concentrative, healing, or movement-based. just as I talk about sort of movement-based meditation, anybody who was in the pre-conference workshop or has looked up the paper that I posted on Hoover, is that these are sort of descriptions that are mapped to the RIBS taxonomy. And the RIBS taxonomy is a taxonomy of religious health interventions in behavioural science, which we did to kind of try and enable the language around religiously integrated interventions to become much clearer and able to identify what's going on. If you look at all the literature, things are described in so many different ways, and there was no way to be able to, if you're doing a systematic review, be able to kind of synthesize that and say, well, actually, we know that this is similar, or we know that this is what that means. So that's a whole other body of work, but do look that up. It's not just around sort of nutrition-related diseases, it's the whole lot. And that's really good if you're developing interventions to kind of map them to that, so that we start to develop a shared language, so that everybody knows what we're talking about when we're saying, if we say that sort of meditation was involved, then, what exactly do we mean? Was it movement-based? Was it healing meditation? So those categories are in there. So this systematic review was mapped to those. Yoga was part of the spiritual and religious components as well, and as was just kind of compassion, non-judgment, acceptance and meaning-making elements of things. And so you could say that those first things were kind of more spiritual, perhaps, than affiliated to a religion. And then there were a minority of studies that did have religious components that would include things like religious text, prayer, or faith leader involvement. So just to it's always good to understand not only the religious interventions, but what is that working with, around the behavioural lifestyle interventions. So they also had healthy eating, nutrition education, physical activity, and psychological treatments like CBT, motivational interviewing, and so on. So they were integrated, it weren't just one or the other. And then the control conditions were usual care, non-spiritual aspects, active psychological controls, or just waitlist controls, minimal controls. So quite a mix, really. And then in terms of eating behaviour outcomes, all 19 studies showed that there was a positive change in reductions in binge eating, emotional eating, hunger, and also restrictive episodes in the intervention compared to the control group, and that was consistent across obesity, eating disorders, and subclinical samples. So obviously it's a bit there's a lot of different outcomes, but I'm just going to show you the meta-analysis for this. Not significant. You can see that the confidence intervals cross zero, and there was high heterogeneity. But I think the Cohen's D effect was significant, and I think when we think about some of these things, although we need to look at statistical significance, remember we also need to look at clinical significance as well, and the magnitude of changes in things. Is it a meaningful change? You can have a statistical significant change, but it's tiny and makes no difference. Or you can have one that doesn't look statistically significant because the sample size isn't big enough, but actually it makes a big change on the sort of where people are in terms of their health. Just to summarise, the other outcomes that were looked at were quality of life, body perception, anxiety, depression, weight related studies. And you can see the number of RCTs there, and the short-term aspects, so less than 3 months, you can see where the different trials, what the results were. So for quality of life, 5 out of 7 trials favoured the intervention compared to the control group. So that would be the one that had the integrated spiritual, religious aspects to it. And the longer people followed that for, the bigger the effect. 7 out of 8 was favourable for body perception, 4 out of 5 for anxiety, 2 out of 3 for depression, and then for weight, they all favoured it, but it wasn't a significant, the meta-analysis wasn't significant in either the weight or the anxiety. Okay, so just to give you an indication of another sort of a little change of pace, really. This is a qualitative study looking at an eating disorder intervention that we've done. And this was just really to get a sense of, this particular intervention is something that's part of a charity, a UK charity, and the NHS were looking at, so the NHS and National Health Service were looking at incorporating that into the NHS. But it was really interesting. So the people who run this charity came to me and said, well, they're looking at putting in the NHS, but they've asked us to take out all the spirituality bits. So they'd like it, but without the spirituality. And so I said, well, why don't we see what is the evidence around if that's useful or not? So that's where this study came from. And so just looking at the background around eating disorders, religion and spirituality can both challenge and support recovery. There was also a social media element into this because of the interests of the researchers, and that, that can also be supportive or harmful. And as I said, the study focused on this particular charity, which runs a community-based recovery program for patients and carers. It's got a similar name to my one, but that's just how it was. So the design of this was qualitative study using semi-structured focus groups, 17 participants in total, those with eating disorders, the carers that might be attending, and also volunteers that are supporting. Again, this was a mostly Christian intervention, and there were varied eating disorders around that. 4 online focus groups collected the data, which was audio recorded, transcribed, and analysed with reflexive thematic analysis. And these are the results. So there were 5 main themes identified. And interestingly, I know we've had some discussion already in some of the keynotes around spirituality being around sort of connectedness and relationships. And this actually was all about, when you look at the main themes, it was all about all the different directions in which people have relationships. So relational support from God came as something that provided hope and meaning, but also provided, there was a spiritual struggle identified in that. When I keep on praying, am I not getting better? So there were things there that spiritual struggles that would need to be addressed. And then relational support from people. So obviously people being in a like-minded group, that was helpful. And then, the fact that groups were mixed, sometimes that was beneficial, sometimes it was challenging. Some people were associated with churches, and again, there were mixed under this under this theme. There were mixed sub-themes. Some found churches to be compassionate and supportive. Others found them to be judgmental, misunderstanding, and so they avoided going. And so I think there's a lot to learn from these results around. What we do in all these fields, whether we're in church or in a faith community, or whether we're in sort of health professional side of things. And then in terms of broader than that, there was a ripple effect going out to the wider community around, well, if I've been helped, I want to help others, so I want to go and do something more, was one example. And then social media was, again, the relationship that people have much more broadly with everybody on the internet and with all the information on there, the main thing that came out was that social media should come with a health warning, that online support and recovery communities might be helpful, but there was pro-eating disorder content that was harmful. So the selective and limited use was seen as protective, but just a kind of free-for-all was not seen as good. So the implications of that, I mean, they're pretty, pretty self-explanatory, really. But again, it's around, there are positive aspects around positive religious coping, but there are negative aspects that need addressing around negative religious coping. So again, Arjun mentioned it as well. It's not that, or religion or spirituality, or spiritual care. It's not an easy relationship. We have to think, what are the things that are beneficial? What are the things that are problematic? And how can we help people work through those if that's what they want? So I'll let you read that. So just my final bit then, because I know time is going on, is so that's a sort of walk through the research, and then looking at the integration of this into professional practice. And, it's, as I'm sure you know, if you've tried to do this, you are in a minority. It is a niche area. It's often misunderstood. But with the research that we've done, looking at the evidence base, I've been able to kind of build on that and develop guidelines around how it could be used in clinical practice for dietitians. And then just last month, which is very timely, the Manual of Dietetic Practice. I'll just go on to this first. So translation into professional standards. I think we've mentioned this really already, but it's about being values-based, meeting the service user needs, being respectful, recognizing diversity, not pushing your own agenda, recognizing there's a power imbalance, and the ethics of that, and Arjun mentioned it as well. It's not about trying to change people's worldview of things, the patient being first. And so all of that would come into a dietetic ethical practice anyway, but it's kind of making sure that is really clear. This is the nutrition care process that dietitians use when they go through diagnosing a nutritional need, assessing it, planning what to do about it, implementing it, evaluating the impact of it. And so looking at how spirituality could layer on top of that, it's around bringing in the spiritual assessment into that. And this could be done by asking some simple questions. And these are similar questions that have been used in other professions. But do you consider yourself spiritual or religious? Do your beliefs influence what you're eating? Do you have any spiritual concerns at this time? And I really liked what Neil said in his lecture, is something around, is this a problematic for your belief at this time? There was something that you said around that, which I thought was a really good question. So, and the key thing that is important here is that inquiring whether a patient wants to talk about these things or has these things is neither threatening nor coercive. And then identification. Could some of the problems like have a spiritual concern as part of the sort of cause of it, and kind of considering that as a potential contributing factor. And then in terms of planning, if that is the case, is there a spiritual goal that needs to be set? Does the patient want that? Do they want to talk to a faith leader? Do they want to be signposted on, obviously as AHPs, we are much more generalist, and then, chaplaincies are the specialists. And again, that recognition that chaplaincy isn't only just for the end of life. And then implementation, supporting people to do that, and then following people up and seeing how they got on with it. So this is the manual that's just come out, and so it's It's a definitive reference guide. It's a global text, and it sets the gold standard around evidence-based care in dietetic practice. And obviously, you've seen the research that I've done, and in terms of bringing in some evidence-based aspects to spiritual care, I have been able to get 4 paragraphs in that. So I am pleased with that. And the key points, really, that come across in that manual are that spirituality is a way to seek and express meaning in person. It might be religious, it might be secular. And spiritual care recognises these needs and compassionately supports individuals to find meaning, wherever that takes them. And dietitians are well placed to identify these, and we've seen that unmet spiritual needs are found in a variety of dietetic service users. And then it also highlights that the unresolved spiritual struggles, for example, an unhealthy sense of guilt or negative religious coping, for example, anger at God, can lead to psychological distress, maladaptive coping in eating, that can often be sort of overeating, and hinder self-management of dietary-related problems. And positive spiritual support can provide resource in times of difficulty, and positive religious coping has also been shown to help, particularly around weight control and diabetes management. For those who are in faith communities, particularly the African American communities, there's a lot that supports this kind of care within their church community. And then my last slide is just in conclusion, in practicing spiritual care, dietitians should recognise the evidence-based role that religion and spirituality plays. They should inquire whether a service user has religious or spiritual beliefs that might be helpful or causing them concern at the time, and do signposting. And in this way, dietitians can provide holistic spiritual care that will improve nutrition and dietetic outcomes. That's it.